So I'll go ahead and introduce myself, a little bit about what we do and SeniorLivingGuide.com in general. And then I'll let Kim introduce herself and I'll just do a little intro as well. My name is Darleen. I am the National Digital Sales Director for SeniorLivingGuide.com. And I'm also the podcast host of our national podcast that we have that is a senior focused podcast. I'm joined by two guests that work with seniors at the Senior Consultation Center at Parish Healthcare. We have some really amazing content. If you haven't checked us out, we're available anywhere you enjoy music or podcasts. Just look up SeniorLivingGuide.com podcast. I also help, basically, my main job is SeniorLivingGuide.com, our website where our online users can go on and they can find anything from assisted living, home health, memory care, active adult. It's all in a one-stop, easy to navigate website. It's really amazing that we provide for our online users. So our clients are really super happy because it's really helpful for them to get direct connects with their website and all that kind of fun stuff. So something you're interested in, please let me know. I'll be happy to give you some more information on that. So I want to introduce Kim today with Windmoor Health. She is a clinical social worker and she's worked in the medical health and addiction field for over 20 years. And I'm going to let her give you more information about what she does.
Oh, thanks, Darleen. I'm really happy to be here. And I got to tell you, Darleen does some amazing things for our seniors. The Senior Guide, we get it here all the time, and we really look forward to having it. And our seniors appreciate it as well. So I want to welcome everybody. Like Darleen said, my name is Kim Treanor, and I am the Director of Clinical Services here at Windmoor Healthcare, which is a 144-bed freestanding psychiatric facility. I'm also a licensed clinical social worker, and as Darleen said, I've been in the field over 20 years. I started in the addiction field. That was my SME, my subject matter expert was always the addiction field. Those are my people. And I got to tell you, I've never worked with seniors very much until the pandemic. And I will tell you that the pandemic, I noticed my neighbors, just a real quick personal story. My neighbors were isolated and unable to get out, and I was checking on them like every other day, and I was going to the store for them, and I started realizing that what are we doing for our seniors during this pandemic? Talk about social isolation. I mean, it was bad enough for us. I know I'm a type A personality. It's hard for me to slow down and stop, that I couldn't even imagine what was happening to our older adults. And my CEO came up, we started to open up an older adult unit. I mean, we've always treated the older adults, but we never gave them a unit of their own that was specific for them to feel safe and to get the care that they need, because it's specialized. So when Darleen asked us to do this this webinar, it's about being able to diagnose mental health in older adults. And I think that I know I had a hard time with it at first, understanding which was which. So it's amazing how it's timely, and I learned from doing. So this is what it took for me to understand that, wow, we have a real need out here in the community.
Yeah.
And I'm sure that you have one in your community.
Yeah, I know. And I really appreciate you doing this. I know that, even just talking to people in the senior living community, they're seeing that more and more with their seniors, that they're seeing higher rates of depression, anxiety, all kinds of different personality changes. So really kind of having an idea on how to diagnose what the difference between that is and just something normal aging, it might be a little bit more difficult, because I know that sometimes people look at seniors and they just think, oh, they're not, that we're doing that in the senior housing and living industry, but they're just old. So I think that it's good to kind of note that that's not that's not I mean, that's something you don't just put on someone just because of their age. They still have the ability to have depression, anxiety, addiction, those different types of things as well. So you need to really pay attention to that kind of thing.
Okay. Yeah, so I felt like they got, they really needed a lot more attention than what was happening, you know, and that what they were getting. Okay. Well, maybe I can't. There we go. All right. So bear with me. I'm going to tell you that this is my first webinar. So yeah, you get extra credit for this at the end.
It'll be fabulous.
Okay. So diagnosing, how do we diagnose the mental health in older adult populations? And I want to say that doctors are absolutely amazing, but sometimes they don't have the time to make a decision or to even ask the right questions about their older adults. Now think about the pandemic. So if they're seeing a doctor at all, they're seeing them probably by telehealth. Mm-hmm. And really what they're doing is just calling in refills for their medications and maybe not seeing them, and more for their health than the doctor's office, but they're not getting seen. So when they are seen on a telehealth conference, maybe they're not going to tell you that they're feeling depressed or that they're grieving. You know, I mean, we're not just grieving. Well, besides losing spouses and significant others and family members, we're losing our independence and our ability to socialize. So there's grief is one of the biggest things that we watch for with our older adults. Mm-hmm. And grieving can take many forms. Okay, so knowing that there's dementia and Alzheimer's, they can also suffer from depression, either along with that or it might mimic dementia. So the depression part, when I go through these slides, there'll be specific things to look for to tell when somebody, you know, the questions to ask that they might be depressed. Mm-hmm. So I will tell you that now that they're going back to medical facilities and doctors' offices, the doctors are adding, I don't know if you have this, it's called a PHQ-9, which is a public health, person health questionnaire. Patient health questionnaire is what it is. And what it does is it identifies if somebody's isolated or feeling that they don't want to live anymore, or how much are they having fun. So it's the first one of its kind that the doctor's office are actually using it. You know, they've done it for substance use with the audit tools and the different quick eye-opener surveys for if they're using drugs or alcohol. And then they did it with domestic violence to see if there was, you know, to screen for that. And now they're finally getting to mental health. Because then we talk about, Darlene, you and I discussed how you go to the doctor and they talk about your physical health, but they don't talk about your mental health. They don't ask you, you know, how do you feel? Mm-hmm. And I don't think it's because they don't care. I just think it's because either they don't have time or they don't know how to treat it. Right. You know, so you have to get them to understand that, you know, to treat the patient holistically, we have to include their emotional, spiritual, and physical health. Right. Right. And I think they're not going to come out and say, hey, I'm feeling depressed. Hey, I'm feeling anxiety. You have to kind of also look at the signs and dig a little bit deeper to find out if that's actually happening. Yeah. Well, they might I would imagine. Yeah. Well, they might not even know that they're depressed. They just, exactly. They don't know. Yeah. And if they do have some signs of aging, they really don't know what it is. Mm-hmm. You know, they're just a little more confused, a little more sad, a little more tired. Anxiety is another really, really big one that we have to watch out for. What I've come to notice about our seniors that have anxiety is it doesn't present the way normal anxiety does. You know, where you're maybe tapping your leg, you're you know, you're moving around a lot, your heart's racing, you know, you can't breathe. It doesn't work like that with seniors. Seniors, you might see them start to pick up obsessive compulsive behaviors. You'll see them start to do things repetitiously. And it's not because they forgot to do it or they're OCD, it's because they're anxious and they need to do something.
Mm-hmm.
So you just took everything away. The normal day-to-day routines have been stopped. You know, it's a complete moratorium on any kind of outside movement, and they're lost. So the anxiety, they're just waiting, is something going to happen? And for some of our seniors, they've been through wars. So it's that you don't know what's going to happen next, because,
Mm-hmm.
you know, and they look at this COVID as a war, you know, especially for our older adults.
Yeah. It's been a tough year for them. Yeah.
Okay, so I want to move moving on to substance use disorder. It's funny, you know, we always kid around about, you know, is grandma using drugs? and everybody's like, that can't possibly be. And I'm here to tell you, yes, it can.
Yeah.
And it doesn't happen in a vacuum. You know, older adults that have had history of addiction might fall prey to prescription medication.
Mm-hmm.
But what usually happens is they have never had a problem before, and maybe they slip and fall, or they have a surgery where they're given some pain medication,
Mm-hmm.
and then they don't know that they took it. They might take it again,
Mm-hmm.
and pretty soon it becomes an issue. And one of the big things that I would like everybody to look for is the doctors. They have a lot of doctors that are prescribing different medications. And, you know, each one of them are not talking to each other.
Right.
So that's going to be really, really important, that you want to make sure that at least somebody is communicating with each doctor, and that you kind of know what they are being prescribed, because you want to look for any contraindications, any kind of you know, side effects from mixing medications. You know, I'm not a doctor, but I've seen that happen. But when they have things like depression and anxiety, sometimes the doctors will just prescribe them, you know, a medication.
Mm-hmm.
They'll prescribe them an antidepressant, possibly for anxiety. They could prescribe a benzodiazepine, like, you know, Ativan, Xanax, Valium, or Klonopin. And this is a very serious controlled drug.
Mm-hmm.
And what happens is they tend to forget stuff. And for that, older adults, it's difficult for them.
Yeah.
And what we see, you know, is they'll forget that they took their medication, and they'll take it again.
Yeah.
And then, yeah, go ahead.
No, I was just agreeing with you. I did want to ask, is another red flag is if they're picking up prescriptions from multiple pharmacies? Is that something to be?
Yeah. So I know you're from a lot of different states. In Florida, we have this thing called, it's a prescription medication monitoring program, you know, and we call it eForce. So, and what we do is we're able to get to that. Our pharmacies have it, and every single doctor that prescribes a controlled substance has it. Every hospital in Florida can access this website and get a list of what controlled substances the patient is being prescribed, by who, how many that they're getting, and how often. So that's really helpful. It started, I think, because of the pill mills and the opioid addiction, but it's very, very helpful. I know it works with us. It's helpful for us to see maybe grandma took too many benzos and she's trying to fill the prescription earlier, and that's a pretty much a red flag. The other thing is maybe they're drinking. You know, they have a glass of wine, and I'll tell you, I've learned the first thing you want to ask is how big is the glass? You know, how big a glass of wine are you having, you know, after dinner?
Right.
But the mixing of benzodiazepines with alcohol can be fatal.
Oh, wow.
And that's pretty important for our older adults, especially if they got the anxiety and the OCD behavior. They're gonna take their medication, maybe sit down and have a glass of wine, and then they're gonna say, did they take their medication? And they're gonna go back
Oh, wow.
And
Yeah.
so this is where we see some overdosing
Mm.
and possible addiction.
Mm.
So those are things to look out for. But the prescription monitoring drug program is very helpful in that if you can, you know, if you have it in your state, I don't know how it works in other states.
Right.
It can stop somebody from a fatal, you know, and then the doctor has to look if they're gonna prescribe the medication for somebody. They have to access that website and see if they're getting any other controlled substances from another doctor, and then they won't, you know, duplicate that.
Yeah, let's hope that other states have something comparable.
Yeah. And when we do the question and answer, maybe we can, I'd like to know that if anybody has the same.
Yeah, that would be
type.
awesome.
Yeah, that would be good to know.
For sure.
All right, and then the alcohol use disorder, again, you know, just keep an eye on that, because sometimes that's a tool, especially if you're isolated and you're alone and lonely. And now we have supermarkets that will deliver the alcohol right to you, so you don't have to come to the store for that.
Right. And I do know at the beginning of the pandemic, I don't know if other states were doing the same thing, but even restaurants were doing, you know, mixed drinks to go for a long time. I don't know if they're still doing that. If you're getting, you know, if you're getting a lot of food to go, I know that a lot of seniors are still doing home delivery on to-go items from restaurants. I don't know if they're still providing that or not, but.
Yeah. Okay, so we have to talk about urinary tract infections when it comes to mental health, because it's prevalent. So sometimes if elderly patients don't have a history of mental health, you know, we kind of know, you know, they're usually on our radar if they've had a history of mental health, you know, when they first have the onset, which is what, between 17 and 25 would be an onset of a serious mental illness like schizophrenia or bipolar disorder. But if they've gone their whole life without, you know, without a history of mental health, like they're not on any antipsychotics or, you know, or any mental health medications, and all of a sudden they are having a psychotic break, question that. You know, and for social workers, we are always taught to rule out medical first. Always rule out medical before we start looking at anything else as far as mental health goes. A urinary tract infection will present as a psychotic break. The patients are confused, they're agitated, they could be hallucinating, they get very combative, and they're definitely not like the grandpa that you know.
Yeah.
So
that's crazy, isn't it? That to me is just crazy. But yeah.
And sometimes the doctors don't, you know, they don't pick that up. They just think, you know, oh, they've got psychosis, or they're, you know, it's schizophrenia. Nobody gets schizophrenia in old age. That's not a thing. That's not a thing. Anyway, so UTIs in elderly are mistaken for early stages of dementia, Alzheimer's, and the mental health break. So, and that's an easy fix. However, I want to give you a little caveat here. Make sure if they do that they're not going to be safe if they're left alone. You know, during this time until the antibiotics take effect, they're going to be confused and could be a harm to themselves or others. So sometimes this is how they present into a psych hospital, is based on this. And that doesn't mean that it was a bad referral. What it means is that they're not safe.
Yeah.
And we want to keep them safe.
Absolutely. And we all know you have falling highlighted here, falling I always talk about falling could be, that could very well be the end to a normal life that a senior might have. They will never go back to, potentially never go back to the way that life was.
I keep wanting to say any questions.
And we're getting some here, so we'll definitely address them. Those folks that are putting in your questions, we will address them at the end. So I don't want you to think that we're ignoring you in case you missed that note at the very beginning of the webinar. So we will address your questions. So we are getting some good ones, by the way, Kim.
Oh, good. Okay. All right. I'm going to go ahead and move on. All right. So this one, you know, this one's a little bit tricky because you have dementia. Is it dementia? Is it depression? Is it both?
Mm-hmm.
And it can be any or all. Yeah. So those of you that work with, you know, the ALFs that I see, they're all that work with the nursing homes that work with the elderly patients, you kind of know, you know, and here's the thing, if your gut's telling you that this it's not normal for, believe that,
Mm-hmm.
believe that. Because usually dementia comes on slowly, you know, and gets worse as it goes, whereas depression, if it's coming on later in life, it's going to be abrupt. And it's especially if it's COVID related, it's a situational depression.
Mm-hmm.
You know, that will get better,
Mm-hmm.
but if it gets treated, it does get misdiagnosed a lot.
Yeah.
So dementia, people that have dementia are going to have no psych history usually.
Mm-hmm.
Okay. So, and you know, for depression, they will have a history of depression.
Mm-hmm.
So dementia, the important thing about dementia and Alzheimer's is that they'll try to overcome it themselves. You know, like we do this near miss answers thing. They're going to try and give you the right answer. And depression, they just kind of like, yeah, I don't know. You know, I don't know. Don't know. So
that
so
honestly, that is huge because that's absolutely true.
Okay.
Yeah.
Conceals the disability, like they try and pretend, and I'll tell you what, you know what I've noticed myself doing, and I'll be talking to people, and all of a sudden I'm like, I can't think of a word, like I can't get it. I know what it is, and my tongue just doesn't want to say it, and I keep thinking, what's going on here? But I'm aware of it, you know. So it's when the highlights, so the disability is there, you can see it. So it's not concealing in any way, you know, like I know it's not dementia, you know.
Mm-hmm.
Okay, I'm not picking up words. All right, so the decline in social functioning usually has to do with dementia. However, when you're depressed, the decline in social functioning has more, again, to do with the anxiety,
Mm-hmm.
where you'll do, and depression usually is coming with anxiety over what's going on because they don't know.
Mm-hmm.
Yeah. And then the last two are the stable cognitive loss, whereas depression, one day they're going to be really good for a little while, and then they're going to go, wait, I don't know. And it's kind of the fog that they're feeling. And then the short-term memory loss with dementia and depression, they can have both, short and long-term, but it doesn't usually last.
Yeah.
Okay. There's quite a bit more that are, I didn't add them only because it's rare and they're, you know, so it would just kind of muddy the waters, I think. But go with your gut. If you know the person and you know the patient, you go with what you know. You know, we'll get an alert like that. This is not right. This is not normal. And get it checked out. Get them checked out. Okay. All right. So these are some numbers that I got from National Institute of Health and SAMHSA. Sorry, there's a little fruit fly bothering me. Okay, so 1 in 4 adults experience a behavioral health problem such as depression, anxiety, or substance use disorder. 1 in 4. That's a lot. So it complicates medical conditions. Of course, it reduces the quality of life, and you know, the hard part is it can lead to premature death that didn't need to happen.
Right.
Yeah. So it's treatable. It's catch. You know, we can catch it and treat it. So in 2014, over 11,000 people over 60 died by suicide.
That's heartbreaking.
Oh, yeah. Yeah. Now add that. This was in 2014. Now add the social isolation, not being able to see your grandchildren, not being able to go even during the day, just to go out and go to the grocery store. That was part of what your routine was, to socialize. And we're not getting that.
Yeah. So are you seeing, I mean, do we have statistics at this point for what happened in 2020 with our older adults regarding suicide rate or increased rates of depression?
The depression I have not, I don't think they've pulled all that. It's hard to get those numbers right now. But yeah, they should. They are.
But you definitely saw, you saw a trend upward with inpatient and outpatient care as well.
In the beginning, I'll tell you, no, not in the beginning, because I think everybody was afraid to show up at a hospital. You know, they were told not to.
Right.
So now and they were told to stay home. You know, so because it was frightening, and possibly you're going to get it if you show up at a hospital. So they didn't want to put you. So can you imagine? You need to go to the hospital, but you're at risk of getting COVID when you go to the hospital. So what do you do? And then you have home health care workers that are not doing home health care. So it was a perfect storm for our people.
It absolutely was the perfect storm.
Yeah. So the excessive alcohol use accounts for 23,000 deaths among older adults every year. And again, I think, I don't know that I equate it to they're all alcoholics. It's just that now, what are they doing? You know, they're going to, I'm going to have a glass of wine to relax and go to sleep. Yeah. And like I said, but we didn't know that it was a big gulp glass, that they got from 7-Eleven.
Well, I'll even tell you, my parents never drank. I mean, I was raised Southern Baptist. They didn't believe in alcohol. But I will notice that my dad I started seeing wine in the refrigerator, and I was like, what is this? Because never. He told me that he was having wine in order to go to sleep, for someone that had never drank. So not that I think he ever used it, excessively, but definitely it was something I think he was turning to relax and be able to go to sleep. So.
And there are, again, caveat, always speak to the physician before you make any decisions on medication that's appropriate for you. But they had this lovely sleeping medication called Ambien, and which caused a lot of sleepwalking. And now you mix Ambien and then you drink a lot of alcohol, and it's, again, one of those perfect storms that are not going to end well.
Right.
Yeah. So, okay. So the last one is depression and other behavioral health problems are not a normal part of aging, and they can be treated. And again, we're going to go back to, it's a situational depression that won't last, but it needs to be treated, or it can last. Or, a temporary problem becomes a permanent one when you don't know that it's temporary. So despite the availability of effective interventions, 66% of our older adults are not receiving the care that they need. And these are numbers that are prior to COVID.
Oh, wow.
Yeah.
No, I mean, I agree with you, because I do think that people think that maybe they're just, they're older, maybe they're just tired, maybe they are over medicated, or they make up different excuses for why maybe seniors are having some of the issues that they're having, and not really looking at the fact that they have the capability of having depression and anxiety just like anyone else. And I think that that's something we need to, as a society, rethink and reconsider.
Yeah. Okay. All right. So the SUD stands for substance use disorder. So that could be alcohol. I mean, if it was alcohol, we would say alcohol use disorder, but any substance, it could be. Usually it's opiates or benzodiazepines, which is called, I can never pronounce this, analytics, I think. It's anxiety. The word anxiety is in there. Annex, and it's benzodiazepine use disorder. And those are kind of scary because those are the main things. Those are the only three things that you absolutely need to be medically detoxed from, which is opioids, alcohol, and benzodiazepines. Because if you suddenly stop taking any of these, that you have gone into the addiction mode, you could have a seizure. It could be fatal. So you don't want to, you want to make sure that you get the proper medical help. This, I got it, I'll do it on my own. It really doesn't work for those drugs if you are taking them, if you're taking them in an addictive fashion. So this, there's where I did put the e-force in. So in Florida, we do have access to what's called the e-force, and that's the prescription drug monitoring program. And this, for all controlled substances. So this is helpful to identify contraindications and drug interactions. Everybody thinks it's the DEA and they're just trying to catch traffickers and pill pushers, and that's not the case. I mean, it can stop a death. It can stop an overdose. Yeah. Because they don't know. I don't know what drugs interact with other drugs. So how would I know that what I'm taking could kill me? So, and the other thing, older adults, what do they have? They could have a cardiac doctor. They could have a rheumatologist. They could have a cancer oncologist. They could have a primary care doctor. They could have a psychiatrist. On average, I think, I'm not going to make it up, but I would say there's 4 or 5 doctors associated with an older adult if they're on prescription medication. So they'll have multiple providers. Yeah. And so check the medications if you are in an ALF or if you're doing home health care. So the best thing that I think they've ever come up with are those things that put them in days of the week, that set up your meds for you. Yes. And you know what that helps with? That helps with them wondering if they took their medication or not. That's an easy fix. If somebody could come and put all of those, and the other thing is they can't get it hurts if you have arthritis. You can't get the pill bottles open. So having somebody come, just, a neighbor come once a week and just fill up all of them, it helps them immensely. And then they won't take too much of a medication. Just
Sometimes getting those stubborn seniors to agree to put their pills in that little thing. Sometimes they just don't want to admit they need it.
Yeah. I'll tell you what, we have pharmacies now, and I think that even Amazon is doing it, that they will bubble wrap. And ALFs, I know you guys know what I'm talking about. They will bubble wrap the medications in daily, whether it's morning, noon, or night doses, they'll do that for you, which is, I think it's ingenious.
Yeah, it's like the little vitamin packets that when you go to GNC and you buy your vitamins, it's fabulous. Why would you not want to do that?
Right. Yeah. Well, and so again, look for red flags. Why do you think somebody wouldn't want to do that? Because they're going to take more than they're supposed to.
True.
And they might not do it on purpose, but after a while, it's an escape. Yeah. And then they take a glass of wine and then they think, oh yeah, you know what? Another one of those Xanax will taste pretty good right about now. So that's kind of how it happens. I know grandma didn't decide, hey, I'm going to go out and, try and score some methamphetamine when I'm 80, but so it just kind of sneaks up on you. It doesn't happen. Okay. Yeah. All right. So the anxiety and depression is again, I've seen so many older adults that I would have never guessed that was anxiety. You know, you think you could see that.
Mm-hmm.
And that's probably one of the insidious things about the illness. You know, when somebody breaks an arm and they show up at the ER, they know how to diagnose that. They can see it. They can tell that somebody's in pain. You know, family members, loved ones, they don't see the anxiety and they don't see the depression, so they don't think it's there.
And sometimes they don't want to see it. I mean, sometimes they don't, you know.
No, they can't fix it. You know what it is? You know, coming from a therapist point of view, the deal is that a loved one, you know, when my son tells me something, I want to fix it, you know, and I can't. So it's frustrating, you know, and the loved ones feel powerless when it comes to those kinds of illnesses because they don't know what it feels like. Somebody breaks an arm, somebody else can say, oh, I did that once. I remember how that feels. If you have not experienced anxiety and depression, it's very, very difficult to have the empathy for a person that does, because you don't know, you can't see it. So you can't identify.
Right.
Yeah.
And sometimes I know that you can just say, you know, it's a state of mind. Just change your mind and you won't be depressed. Think happy thoughts, you won't be depressed. They don't understand that it's just not that easy.
Go over it. You have so much to live for.
Yeah, exactly.
Yeah. Okay. So definitely underdiagnosed and undertreated. Symptoms look different in the elderly versus younger populations. They can show up with other chronic issues that will mask the diagnosis. Now, this statistic kind of blows me away, that males 75 and older have the highest suicide rate. Yeah.
And I see that because typically their spouses would pass prior to them. And if they've, you know, it's just got to be harder on them. And I can just see where that would be something that would be one of the reasons why.
Well, you know, males have a role in society as being the hunters and the providers, you know, and now, you know, they lose their spouse or they're retired, and then something happens to their health, and they feel this sense of loss and uselessness. Like, I'm supposed to be the strong one, the provider, and I can't do it. And now throw pandemic into the mix, and now you can't play golf. You can't go out to, you know, maybe to the club with the guys, you know, for what's that called? The 13th hole or the 19th hole, right?
Right.
The 19th hole. That's not happening anymore.
Right.
And you do feel a sense of loss.
Yeah.
And it's grief.
Yeah. It's
so
sad.
There it is. Relates to the idea of losses. Pay attention to the losses. Okay, so a loss of ability. One of the biggest triggers for that would when they lose their driver's license or they know they can't drive anymore. That will be, you know, that's something to look at when if they start giving away their stuff. You know, we look at what are some of the red flags for suicidality. Losing, you know, if you stop driving or the doctor tells you that you can't drive anymore, that's going to be a big trigger.
Wow, the giving away of the stuff. I didn't think about that, but you're right. That would make sense. But you have to imagine if your driver's license, I mean, even you and I think about it. And I think if someone took my driver's license away today, I would die. And I mean, I'm not in a big city. So, I mean, I'm not using, you know, public transportation to get around. And if you're not in that kind of environment, I mean, what do you do? I mean, I can't walk to the store. I mean, it's just, it would be devastating for me. And they think no differently just because they're older. They still want to have that same freedom to be able to do what they've always done. It doesn't change for them just because they're older.
Right. Yeah. Now, imagine that you're very independent and you're not used to asking for help. And now you're not driving anymore and you want to be able to, you have to call somebody to ask them to get you something.
Yeah.
And then those folks are worried about putting them at risk.
Right.
You know, so and then if they forgot something, it's a real burden.
Mm-hmm.
They feel like it's a real burden.
Right.
So don't wait for them to ask you.
Mm-hmm.
You know, offer. And I know that's what I did with my, with my neighbors. I went, okay, I'm going to stop by every other day and I'm going to check on them and see,
Mm-hmm.
let me bring stuff that you need. I won't, because if you wait for them to ask, they won't.
Mm-hmm.
They just won't.
Yeah, making sure that they have consistent care in place so that it's just consistent and they're not every day, every week, hunting and finding help in order to, survive on groceries, food, transportation, whatever. Perfect.
Yeah, even if even if you just stop by to say, hey, I just stopped by to chat or to pick your
Mm-hmm.
brain for something,
Mm-hmm.
And that's really, really important.
Right.
It's not so much the material things about getting, it's just sitting with them and being company.
Yeah.
Because they've lost that too.
Yeah, absolutely.
Okay.
Absolutely.
Okay. So here are some of the signs of depression in older adults that you want to, a biggie, really, really big one is the appetite.
Mm-hmm.
I know that those of you that work in an ALF and work in nursing homes, you get that. It's the appetite. They're not eating the way they used to.
Mm-hmm.
They might be sleeping a lot more. They don't want to get out of bed. Concentrating. And here's that feeling restless, the fourth bullet, feeling restless or on the edge. That's the anxiety.
Mm-hmm.
That's the anxiety, the worry and feeling stress. Yeah. So another big one, I'll tell you that I was actually, I didn't think I could learn something that I never had any idea of before, but the digestive system plays into so many issues that we have, that depression, anxiety, and believe it or not, substance use disorder, the digestive system has a lot. They're all connected.
Mm-hmm.
They're all connected. And I think even trying to figure out, how we used to figure out, is it nature or nurture? Is it a genetic thing? Some of these are they predispositioned?
Mm-hmm.
And if you think about the bacteria that in our digestive system, they are so individualized and unique to the person, like our DNA is.
Mm-hmm.
And this is why all of the years that we have been studying addictions, we have been studying depression, mental health, schizophrenia, bipolar disorder, the digestive system definitely plays a part in that.
Wow.
I found that absolutely fascinating. So
that
pay
is
attention.
Fascinating.
So pay attention if they become constipated or gassy, maybe gastritis. All of a sudden they'll start using Tums like they're candy, which sometimes they can be. But those little things,
Mm-hmm.
I never realized how much it plays into it. And it's something so simple.
Mm-hmm.
Okay, so the depression is they feel like I've heard them say that they feel like they're crawling out of their skin, and like why do you feel like you need the wine? Because I feel like I need it to just be myself. So it makes
Mm-hmm.
them feel better. And that's a red flag right there.
Yeah.
So the sadness and hopelessness, especially now,
Mm-hmm.
that it's definitely not hopeless.
Yeah.
So the feeling flat or having trouble feeling positive emotions, the engaging in high risk activities. So I'm going to tell you that I've seen some really feisty folks that are going to do it no matter what.
Yeah.
They're going to go to the grocery store and damn it, they're not wearing a mask.
Yeah.
Like, nope, they're not going to tell me what to do. I'm going to be okay. Yeah, and I see them here in the hospital, and nobody's going to mess with them.
Mm-hmm.
But the high risk behaviors, and believe it or not, for some older adults, it's sexual in nature. which just is amazing. If you start to see that behavior, you've got to know that there's that's not that there's anything wrong with that, but when
there might be something deeper.
Well, when you have somebody that's like had one partner most of their life, and then all of a sudden you see them having 2 and 3 in a week, you might want to go, whoa.
Gotcha.
Or they're not, they might not think about the safe sex part, the condom. And grandma and grandpa still get to have sex if they want to.
There you go.
Those are not fun things to have if it's your loved ones, the conversation. But for those of you in the professional field, which most of you are, I would say pay attention to that stuff, because they're just, it's depression. They're trying any way to get out of it. They want to do anything. All right, so the obsessive thinking and compulsive behavior, that's also part of how they feel. They're going to do something. When you can't fix the inside, you're going to fix everything on the outside. So they start nesting and cleaning, and they want things to be perfect, and the picture's not straight, and they're, and it has nothing to do with the picture being straight. It has to do with they're not feeling like everything is okay inside of them, and they will tell you in these ways. Thoughts and behaviors that interfere with work, family, social life, and then unusual thinking or behaviors that concern other people. Okay. Oh my goodness. Okay, anxiety in older adults. Again, unrecognized. Pay attention to these anxieties. And I was talking to Darleen about it the other day. They're less pronounced. They're different because you see, again, somebody's tapping their leg. They're talking really fast, and they're doing all kinds of things. And they feel like their heart's pounding. Maybe they're sweating. Their palms are sweating. And that's not happening with an older adult. They could sit there and be calm as can be, but they're going to get up and do the same thing like 4 or 5 times.
Yes.
Look at that. Look at that. They're like, oh, what do I got to do? And the sad part is if we don't pay attention to these symptoms, they're going to get worse. They don't get better. Worse.
Yeah.
And the lack of treatment is what it gets worse. Okay. Oh my goodness, it's late. Is it late? It's late. All right. Social isolation. So, I want to go over that. The very first thing is a quote from the American Psychological Association. And they stated that social isolation and loneliness may represent a greater public health hazard than obesity does. Now, I want to tell you that they said this in 2017. So just imagine what it means now, that if that was a public health worry, imagine how much how magnified that is now.
Yeah, to me, that quote, when you first shared that quote with me a couple days ago, I was just, it makes complete sense, but it's true. And it's something that we really need to start thinking about as we're coming out of this pandemic. We need to start focusing on those folks that have been lonely, they have been isolated, and making sure that we're reaching out to them and making sure that we're connecting with them and they're not getting forgotten, as things are becoming more open up and they can have that connection with other people again.
Yeah. I can tell you in our older adult unit that the patients that come and stay with us, each day as they get better and they get stabilized on their medication, it's like the social event of the season to be there. And it's such a warm, I get goosebumps, when I go over there and I see them and they're all, chatting, and you're trying to get in a word edgewise, it's not happening. Yeah. And they're exchanging phone numbers with each other, and it's just, wow. And they have so much to say. and so much to teach that it's wonderful to do that.
I love that. I love that. And I absolutely agree with you. It's seniors, if you let them talk and tell their stories, and you can learn so much, and their stories are amazing. I wish my kids were, would sit and listen and really engage and get out of this and really just, I think we just have so much to learn from our seniors, especially a lot of those that are vets that have been through so much in this country, to kind of hear their stories, because one day they won't be here to tell them.
Right. Yeah. And unless we ask questions, we're not going to know. You know that I have that great story about that there was a 4-generational family reunion, and the great granddaughter went up to her mom. They were cooking a ham, and she said to her mom, why do you cut the tip off the roast? And she said, I don't know, because my mother did it. So the girl went to the grandma and said, why do you cut the tip off the roast, grandma? And she goes, I don't know, my mother did it. And then she went to great grandma and she said, great grandma, why do you cut the tip off the roast? And she said, because the pan was too small. So they went on with these tradition, and if she didn't ask, she wouldn't have known. And I think that those little tidbits of why we do some of the things that we do, and they get handed down, I think it becomes more endearing. Is that family probably still going to cut the tip off the roast? Yep, probably, just because it's part of their tradition. So the last thing on this slide I want to talk about is the human interaction and touch that our elderly has been deprived of for the last year, and maybe longer. So remember that they're losing their spouses. Right. They're losing their loved ones. They have not been able to visit their grandchildren. All of that, and one quick fix that I can tell you as we get the vaccines, of course, and they get to visit with their families again, sometimes the touch could just be a massage. Maybe having them feel better is, get them a massage. They really, the human touch, that we thrive on that.
Sure.
And what's happening is we have a failure to thrive, and we need to figure out how to fix that. Or get everybody a puppy.
Yes.
We can get everybody a puppy. Okay. So I'm just going to tell you that our hospital, when we started this older adult unit, we've had some successes with these practices. So I don't know. I can't speak for everybody else. I don't know what states you're in and what kind of resources that you have. But what works, if you're going to do an older adult unit specifically for them, make sure that it's staffed well with psychiatrists, RNs, a CNA, and a therapist, of course. I don't know if you guys use these are I just completely lost the scales, the assessments that we do, the surveys. I told you about the patient health questionnaire, the PHQ-9, and the geriatric depression scale. It's amazingly, it's in doctor's offices now, and any place that you go to. The audit C tool is kind of universal, and that's for alcohol use disorder. And then the Beers criteria, AGS, is for to determine if there's an interaction with any medications that you're taking. And then the last one is the generalized anxiety disorder. So they have them. So I would suggest any one of those would be good, but they're definitely going to be different than the normal depression scales or anxiety scales that we see for younger folks. Talked about puppies and touch. So pet therapy is an amazing trick.
It truly is.
Wow, it's just absolutely wonderful. Then we have recreational therapists that do chair yoga, and we have the sensory cart for mild dementia, mindfulness exercises. And then, of course, the therapies that you use. The cognitive and dialectical behavior therapies, I can tell you that they really don't work for Alzheimer's or dementia, and that's another way that you'll know that they work very, very well for anxiety and depression. Okay, so we also we'll try to step down our older folks from inpatient to what we call a partial hospitalization program, like a PHP, where they go during the day and then they go home at night. And we can use that, or the intensive outpatient. That could be, even if you could find a day treatment program, because especially if they're home all day by themselves, they might not need as an intensive inpatient setting for their treatment, but maybe just getting out, especially if it's situational depression. Again, when you see them start to socialize with each other, you notice that they're not depressed anymore.
Yeah.
So
that's good to see.
Yeah. And sometimes it takes care of itself. And again, they need that human interaction. So the last thing I'll tell you is for severe resistant depression, we know that ECT has been very successful. And ECT is, I'm going to get this wrong, electroconvulsive therapy. And
we actually had someone ask that question, so I'm glad you answered it.
Oh, good. Yeah, I was thinking, I usually get this wrong. But, and, we do it here. And I would tell you that, because I go back to thinking one flew over the cuckoo's nest. So yeah, no, not doing that. Not having a family member do that. But I will tell you, I watched an 85-year-old man who was very flat affect go into ECT. And he came off the elevator and he was dancing down the hallway. And that was an immediate result. Granted, I think it was his third session. They do sometimes between, I want to say 3 and 7, maybe 8, depends. But sometimes it works immediately. But this is for patients that have really tried every antidepressant and they just have that flat affect. And there's no pleasure in life at all. Yeah. And this gives that back to them. Okay, so the last thing, caregiver fatigue. Please take care of yourself. All of us, all of you that are out there are all first responders. And you have to take care of yourself. So I don't care what you call it. It's called vicarious trauma. It's caregiver burnout, whatever you want to call it with a fancy, lovely name. You can't pour from an empty cup. Right. So yeah, you need to practice self-care. Get yourself a massage, manicures. Those are amazing to me. NAMI, we have NAMI here, a national, I don't know if you have that in other states, but it's the National Alliance for the Mentally Ill. And that's a really good support group for the loved ones of those suffering with mental illness. And then we have a new thing, they have Alcoholics Anonymous and Narcotics Anonymous. Well, here they just started this chapter of Trauma Anonymous, which again, for the folks that have gone through this pandemic. So none of us got furloughed, right? Like we're all working, right? We worked right through this pandemic. We never got to take time out, and we watched patients die without their loved ones. I mean, we watched this, and we've held this in. We need to take care of ourselves, and we need to join a support group and talk about that stuff. Yeah. No, I think that's a great idea for caregivers in our industry. I think that a lot of these folks have been through a lot, and now it's time to kind of decompress. Yeah. It's grief. It's all grief. It's all grief. Okay. All right, we have lots of questions, and I know we've kind of gone over our time, so I'm going to go through them pretty quick because I really want everyone to be able to get the. If you have questions, go ahead and put them in the chat box. Some of you have been putting question and answer, and I'm going to flip over to that to make sure that I get your questions answered as well. So I have ECT should sometimes be used first because many antidepressants have side effects. Is that okay? You're right. I got to tell you that if you are a self-payer, that would be wonderful. Insurance companies will not cover ECT until you have exhausted every one of the antidepressants.
Oh, wow. Oh, that's,
Yeah.
So
Yeah.
in South Carolina, drug monitoring is called Scripts through DHEC.
Ooh, I'm going to write that down.
Write that down.
DHEC.
DHEC. Mm-hmm.
Cool. Thank you. Okay.
I'm trying
Memory
to do
loss.
this where it's slow. It kind of goes fast. I noticed less anxiety, depression in the beginning of pandemic, but noticed to see the change in the summer as well. So there was a comment on that. One person, Nana, I'm not sure I pronounced that correctly, knowing your residents helps a lot. And that's absolutely true. If you know your residents, you will be able to see those changes, I'm assuming.
Don't second guess yourself. You know them. Trust it.
Mm-hmm. I'm going to be sending this link out to everyone, by the way. Tools for older adults with substance abuse issues aren't abused. For this, everyone needs to be treated with compassion. It was just
Absolutely.
a comment. Someone asked about what about psychosis versus mental health emergency? I'm not
I
sure.
don't know what the, yeah,
I'm not sure what the question was per se.
Mm.
How can we check if physicians or pharmacies are actually using that tool to check prescriptions?
Ask them. Yeah. Ask them if they're using the prescription monitoring drug program.
So you just have to ask. There's no way to see if they're logging in or anything like that.
Mm.
Okay.
Well, I can tell you that physicians have to, like in our state, if they have a DEA number and they can prescribe controlled substances, it is their responsibility because they will get fined.
Okay.
If they overprescribe, they will get fined.
Okay. So how often would a medication review be needed for an individual?
I would, every time they see another doctor.
Okay. And then this was at the beginning of the presentation. So the question might be premature, they said, but why did you separate substance use abuse from alcohol use disorder?
Well, because substance use disorder actually encompasses all of it. It encompasses, we're just going to say they have a substance use disorder. We might not tell somebody that, we might not say, well, they have methamphetamine use disorder. However, we would diagnose it that way. So it used to be we could say that they were polysubstance dependent back in the DSM-4. We don't do that anymore. The DSM-5, which is the Diagnostic and Statistical Manual for mental health, it's kind of like our Bible. What we do is instead of polysubstance dependence, we've termed it a substance use disorder, and it's either mild, moderate, or severe. Mm-hmm. And the reason that they do that is because, and they have to identify each drug. So that's why they just encompass it for simplicity. But I mean, for like grandma could be, she could have benzodiazepine use disorder. She could have, along with alcohol use disorder and opioid use disorder. But we would just say substance use disorder just for the sake of simplicity, and also not to put her stuff out there in the world. It's easier.
Okay.
And it's a little more private.
Okay. So I had someone ask, what tools are good for memory loss? Yeah,
that's a difficult one. I honestly, I don't know, because I don't work with I don't work with the older adults that have dementia. We use a lot. The sensory cards that we have is really, really good for that. If you just Google sensory cards, they'll tell you. But there's concentration games, puzzles, trivia questions, things of that. Is what we use? But because dementia is not something that if they are too far into dementia, it's difficult.
Mhm.
And I'm not an expert. I don't know. I'm sorry.
Right. A dementia care specialist would probably be your best bet. Okay. Also, someone made the comment that they've had some of their elderly patients that have had mental health emergencies just related to lack of sleep.
Absolutely. Lack of sleep will drive you crazy.
That'll drive anybody crazy, got to tell you.
Absolutely, literally, yeah. So yeah, you have to get that, and if we want to know, and you want to ask a specific question, are you having trouble falling asleep or staying asleep? Because that's going to be important for the psychiatrist to know.
Right.
And it'll be treated differently.
Someone said, when looking at a problem, ask yourself, whose problem is it? I'm not sure exactly.
Okay.
Yeah. I'm not exactly sure what I guess I don't really understand that. And then there's some conversation about the UTI. It can be diagnosed, localized symptoms. Up to 50% of seniors have bacterial colonized in their urinary tract.
Yep. Good. Yeah.
And treating for UTI without localized symptoms can easily lead to C. diff infections or other multi-drug resistant infections. If there are behavioral changes, behavioral could be assessed as well as medical. Do that PHQ-9 in addition to medical testing. I don't know. It was just a comment.
That's exactly, yeah.
That was more above my pay grade.
I would say that's way more, that's medical. That is absolute medical, but it nailed it. You are exactly correct.
Okay,
yeah.
That was from Amy Jo Lundgren. Thank you. Yeah.
I finally see this one. Sleep deprivation could be caused by drug interactions. Absolutely. Mm-hmm. Especially antidepressants could work to keep you up. Yeah.
So Evelyn said, I think the whose problem is it question means, what if a person's behavior is causing you angst, but the person is fine? It's not a real problem.
Correct.
Possibly. What's the best recommendations to prevent UTIs? Oh.
That's a medical question.
Yeah. Yeah. I'm definitely not going to answer that. I'm not sure that there is one for our seniors.
Yeah, I mean, normally I know from, personally, always shower, clean, drink plenty of water, cranberry juice. But I think sometimes if you're prone to them, you're prone to them.
Yeah. Yeah, for sure.
Okay, so nutrition.
I don't know, you might really, Google might be an excellent source just to get some information or talk to a physician. But a physician I wouldn't recommend.
So diet, let me tell you, nutrition is really, sorry, I cut you. I just saw diets. Yeah. We have when they're here with us, we have a nutritional assessment done, and there's actually a specific nutritional assessment for older adults. Really important. Good fluid intake. There you go. All right, and actually I might even have it with me. Hold on. Assessing nutrition in older adults, really, really important.
So I have one that says UTI prevention, good fluid intake, good peri-cleanliness, white front to back, cranberry supplements can help if you are not contraindicated in the senior. I'm not sure what that word is, so I do apologize.
Contraindicated, yeah.
Contraindicated, okay.
Yep.
So.
Yeah, because they might not be able to take cranberry supplements for one reason or another.
Okay, very good. Thank you so much. That is fabulous advice. Really appreciate that. Yes. Well, I think we have way exceeded our time frame today. Yeah. Please note that I will be sending out the link. There are no CEU credits for this. I know I've had that question multiple times, so I do apologize for that. I will be sending the link out to everyone. You're welcome to share it. It is a YouTube link, so it's shareable to everyone for whoever they would like it to go to. It will also be available on our SeniorLivingGuide.com YouTube channel, along with our other webinars. So please feel free to check those out. And thank you for joining us today. And thank you, Kim, so much for joining us. This was so much amazing information. I appreciate it.
Thank you. Yeah, thank you very much. I really appreciate your time. It's really important.
Yeah, it's important stuff. All right, everyone, have an amazing day and an amazing rest of your week.